Can you guys see slides? Thank you. Okay, I'm going to start because we've got a lot to get through. Um, how this is going to run, I'm doing vascular, breast, and urology, hopefully, if we've got time. If I can't finish everything, then next week, the person who's doing the revision session will go over the remainder of the slides. There's quite a lot of cases. I'm going to give you guys about a minute for each one because in the exam you'll have about 60 seconds. So you can practice doing it in time conditions. Any questions, shout out because I can't see the chat. And if you have any questions later on, then just email me. And any problems, just stop me. I don't mind at all. So first case, you guys want to work through that? Also, you don't have to shout out. Just kind of come up with the answer in your head. If you want to, then fine. But try and let everyone come up with a chance to answer. Okay, hopefully you guys have had a chance to read through that. So most likely diagnosis for this one would be chronic limb-threatening ischemia. The reason why, so worsening left leg pain occurred when walking long distances, but now it's gotten worse. So you're thinking, okay, this is vascular, started off on the mild end of the spectrum, which would be a kind of intermittent claudication, and now it's gotten worse. It's not acute limb ischemia because it's been gradually getting worse. Um, and cellulitis, we don't really have any kind of inflammatory or infection marker in the history. DVT, he hasn't mentioned any signs that would make us think a well score is high enough. So no kind of swelling or making it more likely. We haven't really heard that he's a vascular path really. So kind of like the diminished pulse and the fact that it's been going on for a while and getting worse. And it started with a kind of claudication would make us think it's a chronic limb-threatening ischemia. So yeah, these two, just think of it like a sliding scale. That's quite helpful. Starts off with a kind of cramping leg pain, typically only when walking or exerting yourself. Usually you need to ask what the specific distance is. It will typically be like, oh, I can go to the post box down my street, or I can get just up one flight of stairs, and then it will get worse, which you can kind of measure in a history. And then it will go to chronic limb-threatening ischemia, which used to be known as critical limb ischemia. If you see the two, they're interchangeable. That's when it's kind of relieved at rest, but mostly constant pain rather than just brought on by exertion. They typically have a history of dangling a foot off the bed at nighttime, and there might be tissue loss with ulcers. And in a history, it's also quite a good idea to ask about erectile dysfunction. Most patients won't bring it up, but you can impress the examiner by asking because it tends to, yeah, cross over. Second case, I'll give you about 45 seconds, see how we go. If it's too fast, let me know. This is the typical one of read the the last bit of the stem. So most appropriate next investigation isn't the same thing as gold standard. Okay. So answers D, ABPI. We'll go through this in a bit more detail, but all of them are kind of, except maybe ECG, are kind of decent answers. You could do all of them. You're thinking, okay, she's come to a primary care setting, so we're not going to go into the most intricate investigation, which kind of rules out A and C. B is reasonable, but it's just not first line, especially in a GP setting. And if you're wondering, duplex is ultrasound mixed with Doppler. So that's why it's like two things mixed into one. So it's like a picture as well as you get the like sound of each pulse. So just to go over, these are the investigations. Also, you will get the slides. There's some that I've kind of suppressed because of timing, but you can look at them all in your own time if there's anything that you're struggling with. So just like I mentioned, ABPI is the first line. Digital subtraction angiography is the gold standard for peripheral arterial disease. So that involves, there's a photo of it on the next slide, but it's essentially two X-ray scans, one without contrast and one with contrast, and then you take the two images away from each other. It's really helpful because when you're doing the scan, you can also do the kind of interventional radiography at the same time, which is helpful. Duplex, we talked about CTA and MRA, suitable tests, but in a tertiary center or in a hospital setting, not in a GP practice. Brief mention on ABPIs. These are helpful to have in your head as rough ballpark figures. Around 1 is normal. It's a ratio of the kind of blood pressure index in your ankle and in your arm, so brachial. Typically, yeah, around 1 is normal. Over 1, you're not too concerned. It happens when you age. You just get calcification of the valve or the vessels. Less than 0.8, we start classifying it into some form of disease. And this is a picture of the DSA. Don't get too bogged down into it. It's just something to know as the gold standard test if they ask. And then best medical therapy. So typically you're just going to do antiplatelets, platelets and statins. So you're going to manage their kind of cardiovascular risk factors. Same with lifestyle, so exercise, weight loss. Always bring up stopping smoking. Refer to services if you can in an OSCE, and then manage risk factors as well. Okay, and then if you're going to operate, typically a third get better without treatment just by kind of doing lifestyle measures, and kind of getting collaterals round. A third will stay the same, a third will get worse and need kind of interventions. So you're going to be doing interventional radiography usually, so you can balloon or stent. You can do an open procedure, so you can open it up and scrape out the vessel if there's any occlusions, or you can do a mixture of both. And then worst case scenario would be amputation, but typically that's only about 6% of patients. Okay, two kind of important differentials to consider, they come up all the time, is a kind of spinal claudication. So it sounds a lot like intermittent claudication. They're kind of walking a certain distance and they have like that kind of limb pain. Ways you can differentiate it, they typically have a history of back pain. It helps if they change position because it's usually due to like a spinal canal stenosis. So if they like alter the way they're standing or like sitting, then they can relieve that stenosis and get rid of the symptoms. It's usually like a sharp neuropathic pain, and they may or may not have weakness or numbness of the like surrounding muscles. So that's just something to think about. And then the other thing to think about is like aversion or like a subsection of PAD, which is called Lariche syndrome. So it's a triad of buttocks wasting with claudication with erectile dysfunction, which is why it's really important to ask about erectile dysfunction because most of the time patients won't bring it up, but it does come up sometimes. And if you see those 3 symptoms in a question stem, then that's the diagnosis. Okay, next question. Again, about like 45 seconds. Let me know if it's too fast or too slow. Okay, so with this, hopefully the six P's are going through your head. Acute limb ischemia, so again, short term, and you're thinking that he's got kind of perishingly cold, can't feel pulses, so pulseless, and kind of pale with history of peripheral arterial disease. Um, no mention of kind of issues with dorsiflexion, so that would kind of remove C. Compartment syndrome, you can feel the compartments and they're soft. So typically with compartment syndrome, the classic feature is this excruciating pain. It would be quite tense to touch and they'll just be like writhing in pain. It's really, really, really painful. Popliteal entrapment syndrome, you just haven't had any mention of that. Again, it's more of a mechanical thing. This patient's got a history of peripheral arterial disease and has the classic features of acute limb ischemia. And it's most likely due to the surgery, not the tourniquet. Okay, so a few things, 6Ps just to go over. Hopefully you guys have covered that at some point. Big thing to note that it's a surgical emergency. So if they start talking about then like next best thing to do in terms of management, then the first thing you need to do is stabilize the patient. So that's going to be calling for help, A to E management, and you're going to need to figure out what's causing the limb to be critically ischemic and then sort that out ASAP. First line investigation will be a Doppler ultrasound because typically they're in hospital already, and you always need to do a sensory motor exam. So you are going to do a bit of a neuro exam. That's how you complete a vascular because you're worried about losing nerve function at some point. Causes, again, think about where is the clot, where is the block. Can either be in site, which is a thrombosis, or if it's moved, then it's an embolus. And then look for the source. So if it's the heart, do they have AF? Have they had a recent kind of cardiac intervention of any sort? So if they had CPR or ECMO treatment, that's a massive risk factor. If they've had any kind of prosthetic heart valve surgery or any grafts or angioplasty, then that's a massive deal as well. Because you're just thinking anything that's going to cause vigorous damage or vigorous kind of activity to throw off a clot. And then if they've got things that make them more likely to clot, so if they've got aneurysms because there's just like a space for blood to pool, or if they've got the classic things like a hereditary condition that makes them hypercoagulable or cancer or something like that. And then management, so A to E management, they're going to be in pain, so give them some pain relief. And then IV heparin is the main thing you need to remember. And then you can call for vascular and either do endovascular or open procedures as necessary. Amputation is last resort. You can throw it in there, but most don't get that. Okay, next case. Okay. So hopefully in MCQ land, any pain that's severe and radiating to the back in the abdomen, you're kind of narrowing it down to pancreatitis or an aortic dissection. We think this patient has an aortic dissection because he is very hemodynamically unstable. So with a blood pressure that low, he's clammy, he's uncomfortable. Just think like this is definitely a vascular problem, and it's quite acute, so it's sudden onset. And he's a 67-year-old man, which is unfortunately the age range and the demographic that typically has that. Why it wouldn't be an aneurysm, so typically they're pretty stable unless it's like ruptured. And you'll typically be described as like a pulsatile abdominal mass. An MI could present like this, but typically it's chest pain rather than abdominal unless they are diabetic or elderly with a kind of atypical presentation, or sometimes women as well. And then ischemic colitis is typically a quite like diffuse abdominal pain. They're just like really uncomfortable and tender everywhere. They can also be vascular paths, so that's sometimes difficult. Okay, aneurysms. So this screenshot, it's helpful to know. Um, you basically just need to remember the diameter and then what happens to each. So no, everyone gets screened. Oh, if you're a 65-year-old man, you get a one-off screening. That just happens. If it's less than 3 centimeters in diameter, then we leave you alone. If it's between 3 and 4.4, then we rescan in 12 months. If it's between 4.5 and 5.4, we rescan in 3 months. We bring it a bit shorter because it's slightly more concerning. And if it's over 5.5, then you're going to get a 2-week wait referral to vascular, and they're going to treat most likely. You're also going to get a 2-week rate referral if it's rapidly growing, regardless of the size. So if you start at like 2.7 centimeters and then we find out that it grows to like, I don't know, 5 centimeters within like 2 weeks, then we're stressed and we're going to refer you for a 2-week wait as well. So just bear that in mind. There's 2 criteria for a 2-week wait for a AAA. That's if it's over 5.5 centimeters and if it's growing quickly. So with that in mind, this question should be a little bit quicker. Okay, hopefully that's enough time. Um, so he's over the 3 centimeter cutoff, so we're gonna start worrying, but it's not too big, so we're gonna rescan in 12 months' time. Again, this is the why. If you haven't screenshot, please do. Okay, so treatment, if it's symptomatic, big diameter, or it's growing loads, then we're gonna start thinking about treatment options. EVAR is the way we treat it. So it is quite cool actually. They've come up with a new way of doing it. It's like this plastic mesh that's like collapsible and really tensile strong with a lot of tensile strength. Then you kind of sew it, you kind of cut open the aorta, and sew this instead in place of it. And you can do that either open or endovascularly. And you're going to think about secondary preventions as well. So how are we going to stop this from creating more clots to form? So you're going to give them an antiplatelet, you're going to give them a statin, and you're going to give them some lifestyle advice as well. Okay, dissections. So anything with tearing should get your head thinking dissection, should be a kind of chest or abdominal pain radiating through to the back. They will be hemodynamically unstable. It will either be low or high blood pressure, and it might be unequal in both arms. That's typically quite a good telltale sign as well. They probably have a history of hypertension or something that makes them more likely to have a kind of, yeah, a weak intimal wall. So that might be Turner syndrome because they have a bicuspid aortic valve and they can kind of tear from there upwards, or it can be a connective tissue disorder, so Marfan's or Ehlers-Danlos. Complications, rupture, ischemia, very dangerous, critical, call for vascular help as soon as possible. On a chest X-ray, it will typically have a widened mediastinum with tracheal shift to the right. You may or may not get a pleural effusion. That's less common when it comes up in a question, but typically they'll mention a widened mediastinum if they're going to mention a chest X-ray with a dissection. So just, again, let that be a buzzword for your MCQ land of things. Okay, so the classifications. Usually a question won't ask. If you get it in an OSCE, they might drill you with it, but it's not too deep. Essentially, A involves the ascending aorta and B is descending. That's the Stanford classification, which is what we do, what we use. DeBakey is here for your, like, I don't know, for completion, but no one really uses it, so don't worry about learning it. And that's just a picture, so just think A ascending and B is the other one. Okay, another case, give you about 45 seconds. I see there is something in the chat. Buzzword. Let me go back. I can't remember what I said. Mm. Oh, was it widened mediastinum, perhaps? Yeah, okay, cool. Thank you, Chloe. Okay. I find these questions quite annoying, but it's quite helpful to go through for kind of exam technique because I'd kind of all be right. Okay, so with this one, okay, she's got swollen ankles, which could kind of be all of them. She's got some dark discoloration, so you're thinking, okay, this is kind of vascular. Kind of sounds like venous stuff that we learned about. There's no signs of ulceration or infection, so you can rule out A immediately. Um, so you're thinking, okay, it could be swelling, so it could be B or C, and then there's some eczema, so it could be E or C. And you're basically looking for the thing that answers all of them. So what would have swelling as well as discoloration, as well as eczema, as well as kind of vascular risk factors? And that's going to be C. So you've ruled out A just because there's no sign of infection, and then the rest is just kind of, they don't answer it all in entirety. They could kind of be right if you had half of the stem, but none of the stem is like wasted. So they've given you all of the information for a reason, which means you need to like think about all of them and then find the one that fits all of them, which was really annoying for me to get used to, but one of those things. Okay, so chronic venous insufficiency causes incompetent valves, happens as people age. External compression, so if you're really large and you're pregnant, it's just more work for your veins to push up. So sometimes you can just get backflow for that reason. Frequent DVTs, so if you're hypercoagulable, that's kind of an issue. Or if you're immobile, so think about people who have been um, in surgery for a long time. That's why we give everyone heparin, or just like immobile for other reasons. It's one of the reasons why people in wheelchairs can't get the combined oral contraceptive pill because of that risk of immobility and clotting. You're going to be thinking about venous insufficiency with the skin changes, with any varicose veins, any venous ulcers, any phlebitis, which is a mimic for cellulitis, and any DVTs. Those are just pictures if you haven't seen them yet on the wards. If you do Jerry's at any point, then you will see them because everyone has legs that look like these. It's just kind of like scaly, quite red. You can actually see it's quite shiny and like atrophied as well. And yeah, sometimes they have ulcers, which you will smell. Okay, so management, most of them get stockings. That's why you'll see people getting Dopplers all the time, just to see if it's safe for them to get stockings. If their arterial pressure is not high enough, then we won't, risk compressing them even further. But if it's fine, then you can put them in stockings safely. They'll get them measured to like their foot size and their um, and their APBI as well. And then you can also recommend lifestyle factors as always, elevate them, and then give them moisturizers for the skin stuff. Okay, next case. Okay, so With this, anything that says worm-like is pretty much always going to be talking about varicose veins of some sort. So you can rule out venous ulcer because they haven't mentioned an ulcer and cellulitis with that. So we're thinking something to do with a superficial vein. You can also get rid of A. Varicose veins would just be worm-like, but it's also got overlying erythema, it's also tender, and it's also swollen. So we're thinking, okay, the varicose vein is like inflamed in some way, which means it's going to be C. So this is just inflammation of a superficial vein, usually the long saphenous in the legs, associated with an increased risk of clotting, and it's kind of the same risk factors as VTE risk factors, so cancer or hypercoagulable stuff, obesity, immobility, and you do have an increased risk of a DVT if it enters the deep circulation. Typically, it's not really an infection, it's more of an inflammatory process. So you can just give non-steroidal anti-inflammatories. You can give paracetamol for pain relief if it's really painful. And then you can just do the normal kind of venous insufficiency stuff that you would. If they have a clot that's like thrown off and you have a risk of an embolus, then you can give some low molecular weight heparin as well. Okay, and then just a quick one on ulcers. I think you guys are pretty familiar with it, so this is just for your notes. If you want a screenshot and just have a bit of a cheat sheet for how to differentiate between them. You'll also get it on the slides. And then those are just some pictures as well if you want a screenshot. So typically neuropathic is on pressure points. It looks quite similar to arterial, but they'll just have a history usually of diabetes or something that affects their nerves. Arterial is dry and punched out. It's usually on like a bony prominence. And then venous is typically messy, quite wet, and it's usually in the gaiter area of the legs. Okay, next case. There's a lot of vascular here. I think slightly weighted it because it's more common in your exams than breast and urology, but we'll see how we go. This should be a little bit faster. Okay. So Venus, it's in the gaiter area. She is a vascular path with all of her risk factors. Superficial, she's got the kind of discoloration and hemosiderin, and it's thickened and waxy, which is typical with the eczema as well. This one. So this one, the Doppler is very helpful. Remember, that's a measure of arterial ratio between the ankle and the arm. So ulcer type is more likely to be arterial. Okay, there's a few more questions. Do you guys want to skip on to breast and urology, or do you want to spend a bit more time on vascular? You can do the questions in your own time if you get the slides after. Any preferences? Okay, I'm going to go ahead and skip, and then you guys can look at it later. Hope that's okay. Okay, breast. So, first case for breast. Again, 45 seconds-ish. Okay. So a few things for breast that give you clues. The first is how old the patient is. So younger people more likely to have a kind of fibroadenoma, could have an infection, that's fair enough, or a kind of fibrocystic change with the menstrual cycle. Older patients more likely to get a fat necrosis, more likely to get breast cancer, unless it's a hereditary condition. So that kind of helps you stratify a little bit. Then you want to check, is it tender? Breast cancer typically isn't, and everything else typically is. You want to know if there's any inflammatory markers or infection, because that's going to lead you towards more of an abscess or a mastitis. And then you want to think about the actual like lesion. So if it's mobile, if it's smooth, then you're going to be thinking fibroadenoma rather than craggy and hard, which is more of a fat necrosis picture. And then is it tethering the skin or puckering? Typically, a fat necrosis puckers the skin and the other things don't. So this one is a fibroadenoma. We've got a young woman with a slightly tender lump. Typically, they call it a mobile, like breast mouse, because it moves a lot, and it doesn't change the overlying skin, and there's no discharge associated with it. So that kind of fits the typical picture of a fibroadenoma. Um, it's just one of those, yeah, you just have to learn which ones tick which MCQ box. And fibroadenoma, typically those are the features. So young woman, very mobile, slightly painful, but not massively, no overlying changes, no nipple discharge. And that should kind of lead you towards that. Next one. Okay, I'll give you 45 seconds, quite a lot of text. Okay, so going through that again, so we've got a young woman, so we're thinking less likely to be breast cancer unless we've heard about, okay, I can see a question. Fibroadenosis and fibrocystic change. Yeah, so fibroadenoma is like a solid lump. A fibrocystic change we're actually about to go through. It's typically waxes and wanes with the menstrual cycle. It's less about a discrete lump. There's kind of like diffuse changes on a scan ultrasound, and they typically just have like cyclical pain and like diffuse lumpiness. It's more to do with the kind of hormonal cycle, hence why it changes. And a fibroadenoma is like a fixed mobile lump. So if you're like examining, oh, 1 second. Mm, Fibrinosis. Oh, I don't know what the difference is between those two. Sorry about that. I think it's probably I tried to come up with fibroadenoma and then did it twice. So ignore that. Okay, so this one, yeah, no problem. This one is fibrocystic change. Yeah, so just think about a 32-year-old woman. So she's young, she still has her menstrual cycle, most likely. She hasn't had any trauma, which rules out a fat necrosis. Waxes and wanes with her menstrual cycle and multiple lumps, so kind of diffuse cystic changes, is very fitting with the fibrocystic. Multiple fibroadenomas isn't impossible, but it's unlikely. And the fact that it changes every month with her cycle makes that less likely. Early breast cancer again is unlikely because of her age, unless she's got a family history that we haven't been told about. And then granulomatous mastitis, we just don't really have a picture of it being an infection or her breastfeeding right now. So yeah. Okay. So you can kind of classify breast lumps into benign and non-benign. These are kind of the flag things for each of them. So fibrocystic change, worse before periods, fibroadenoma, mobile lump, breast miles very smooth. A papilloma is usually associated with discharge. It's usually bloody. Um, it kind of has like tendrils that goes through the ducts. It's typically where it presents. So if you think ductal, then it helps you remember that there'll be discharge. The phylloides tumor is kind of, I like to think of it as a fibroadenoma in older women. It's kind of like the version of that. It can be malignant, but typically it's similar to a fibroadenoma, but just think of that in an older patient. A galactocele is a fluid-filled cyst, so if you touch it, it will be fluctuant, and you can do transillumination as well. And typically they will be kind of breastfeeding or around breastfeeding times. And then it can just be atypical hyperplasia, or it could be a radial sclerosing lesion, which is a very classic kind of star-shaped scar. Um, yeah, they'll usually give you a picture if it's that. It's quite rare. This is also a way to helpfully check. So just think about the age of the patient. Cancer goes up with increasing age, and the rest are kind of more premenopausal. And then inflammatory conditions, so fat necrosis, they're typically going to mention in the history that the patient has been hit. Doesn't need to be like massive amounts of force, but some people just develop a kind of hard fatty lump and it's quite craggy. It usually tethers the skin, so you'll get some either like pucking or dumpling or dimpling. Mastitis, just think of that if she's breastfeeding. Usually to treat that, you're going to tell her to keep breastfeeding because kind of stasis is what causes it. So you want her to keep expressing. Um, and then if it's really bad or if she's getting systemically unwell, then you would consider antibiotics. Usually erythromycin is pretty safe for lactating mothers. Um, Duct ectasia is the classic kind of green discharge. It may or may not be bloody. And that's when you're going to get them to kind of try and express so that you can see what the discharge looks like. And then granulomatous, so that can be TB, sarcoid, or fungi. Very rare. Think about it if you've got a kind of atypical presentation or if they've mentioned like a really weird travel history. But I'd be very like surprised if that came up. And then an autoimmune condition as well. Again, super rare. I've never seen that before. Okay, investigations. This is more for you guys to have in your notes, just something to memorize. Screening is at 50 to 70 years old. You get a mammogram every 30 years. If a woman needs screening under 50, then we do ultrasound because, or it's under 30 actually, because her breast tissue is more kind of dense and a mammogram is not helpful. If you need to do a triple assessment, then it's a history and an exam. Remember to ask for a chaperone. But don't ask, you tell them you're going to give a chaperone, otherwise that's a problem. You're going to do imaging, so mammogram or ultrasound under 35, my bad, and then a biopsy, which is usually an FNA or a core. Okay. Okay, and this is just the process of a mammogram, if anyone was wondering. If you need to counsel a patient about it, they're gonna have a chaperone if they need to. They're gonna need to take off their bra, and they put each breast on a plate, and it gets pressed, and then X-ray does a scan of both of them. And then it's usually only if they're over 35. Okay, so quickly on breast cancer. I'm going to give you 45 seconds. Okay, so This I just wanted to hammer home the kind of estrogen-related risk factors. So the answer is nulliparity. So if you haven't had a break from your kind of normal cycle every month, which is what pregnancy gives you for about 9 months, then you just have more exposure than someone who has. So the more children you have, the lower your risk of breast cancer, and vice versa. So if you've never had children, which is what nulliparity means, the higher your risk. Early menopause means you've had a slightly less reduced lifetime risk of estrogen exposure, so that's actually beneficial. Late menarche is the same, so if you started your periods late, you've had kind of reduced time of having estrogen exposure, so that's also beneficial. And then a family history of breast cancer is a risk factor, but it's not for estrogen-related breast cancer. And then smoking, again, is a risk factor, but not for the estrogen part of things. So again, just kind of commit this to memory at some point. These are your kind of increased risk due to estrogen. It can be either because of your cycles or because you're taking extra estrogen. Okay, these are the guidelines according to NICE for when you need to refer someone for a 2-week wait. So if she's over 30 with an unexplained breast lump, then we are worried. Most of them are explained, but if it's unexplained, then we start thinking about that. If they are over 50 with any of the following symptoms, usually unilateral, we start panicking. If there's discharge, retraction, or skin changes, which is pages, like an eczema of the nipple on one side, then we start freaking out and she's going to get a 2-week wait. And then consider a referral, but don't necessarily refer. If she's got a skin changes suggesting breast cancer, so that would be your podoronge, your puckering, or your eczema, or if she's got she's over 30 with an unexplained lump in the armpits as well. Helpful to know. Sometimes they say what the next kind of step would be for this patient, and you need to know whether it's going to be an exam or if you're going to straight away refer her. Okay, axillary lymph nodes, just to touch on a little bit. Sometimes, yeah, see, everyone gets an ultrasound of the axilla. You're gonna look for kind of any thickening or any rough changes. If you have kind of suspicious axillary lymph nodes, then you can do an FNA or a core biopsy. If it's positive, then when you take out the breast lump or remove the breast, then you will also take out all of the lymph nodes in the armpit. If it's negative, then you'll just do a sentinel node biopsy. A sentinel node biopsy is essentially where you inject some dye into the tumor and you try and find the first lymph node that dye reaches, and it will literally be blue when you're doing surgery. And then you'll only excise that one if it's negative. Yeah, so you're trying to find the first node to which the cancer spreads. Yeah, in the hospital in the JR, they typically do a blue dye. You can also do a kind of radioactive one and then track it with a probe, so it will be like clicking when you go near it. And then you'll either do lymph node clearance in its entirety or just the sentinel node if necessary. Okay, so when you're thinking about management of breast kind of cancer, the first question is most likely to get surgery. It's either going to be breast conserving, which we can call either a lumpectomy or a wide local excision, or it's going to be the whole breast is going to get removed, which is a mastectomy. Your decision making between the two is going to be based on the size of the tumor and the size of the breast that it's in. So if it's a large tumor in a small breast, you're more likely to excise the whole breast. If it's a small tumor in a large breast, you're more likely to just remove the lump because there's still enough tissue to cosmetically make it okay. So indications for just removing the lump are if it's a small tumor in a large breast or if it's just one. And it's less effective for central tumors, less effective if it's involving the nipple or the areola, and less effective if it's lobar, obviously, because it's kind of diffuse into the breast tissue. If you do a lumpectomy, then you're going to do adjuvant radiotherapy. If you do a mastectomy, then you don't need to do radiotherapy, and both cohorts are going to get some form of hormonal therapy. So that's kind of the way to think about breast surgery. So first of all, which surgical management? Is it going to just be the lump or is it going to be the whole breast? If it's just the lump, they're also going to get radiotherapy, and then all patients are going to get some form of hormonal kind of chemotherapy as well. Okay, so adjuvant radiotherapy is given to the whole breast after a wide local excision. It's daily over a few weeks. It reduces the local recurrence quite effectively, and you need to warn patients that they might get kind of skin pigmentation. It might be quite dry and sore. Um, they might feel fatigued, and you might also get fibrosis as well. Okay, a mastectomy if you've got a large lump in a small breast, or if you've got a kind of risk reduction management plan as well. You can just remove all of it and all of the axillary lymph nodes. Um, Typically, nowadays, you spare the pectoral, so it's all above the pectoral muscles. If someone has had their pectoral muscles removed as well, they're typically quite like older and had the surgery back in the day when that used to be the way we did things. Um, so yeah, those are the kind of indications to be aware of, which is the opposite of the ones that you would do a lumpectomy for. Okay, so this is a bit about hormonal therapy. I'll give you guys 45 seconds. And just to let you know, ER is estrogen receptor, PR is progesterone receptor, and HER2 is whatever the HER2 receptor. Okay, so 45 seconds. So this one is tamoxifen, which is an ER. Oops, that's an estrogen receptor one because she is estrogen receptor positive. What's going to kind of guide your thinking with this? So she had a total mastectomy, so she doesn't need radiotherapy. She had a sentinel lymph node biopsy and it was clear, so she doesn't need to get the complete node clearance, so you can get rid of D and B. Herceptin, she's HER2 negative, so that's not going to be useful, so you can get rid of C. Your two options are A and E. If she still has her periods, then you're going to go for E because that goes directly towards more centralized estrogen receptors. Tamoxifen does. Anostrozole is an aromatase inhibitor, which is what we give to postmenopausal women because it blocks the peripheral breakdown or conversion of estrogen. So if your uterus is no longer kind of active and producing estrogen, then tamoxifen isn't going to be useful for you. But you still have peripheral receptors and peripheral conversion of estrogen, which is a problem. So if you've got a postmenopausal woman, you're going to try and block that pathway. And if you've got a premenopausal woman, then you're going to do tamoxifen. And the definition of menopause is if she hasn't had a menstrual cycle in the last 12 months, not just how old she is. So typically that's around 51 years old for most women, but not always. So just ask when her last cycle was. Okay, this is the other side of things. Okay, so this is the exact same kind of scenario. She had a total mastectomy, so she doesn't need to have radiotherapy. Her lymph nodes are clear, so she doesn't need to get clearance. She's HER2 negative, so she doesn't need Herceptin. And then she is postmenopausal. Um, Actually, should have said that she hasn't had a cycle in 12 months, but 72, we can kind of assume at that point that, yeah, A would be the best hormonal treatment to give her. So this is just to summarize it. If you want a screenshot, I'll note that down. Okay, Herceptin, if they're HER2 positive, this is the monoclonal antibody that we give. Targets the tyrosine kinase inhibitor, receptor, and it's IV once every 3 weeks for a year. Yeah, that's all you really need to know. Okay, this is just, I think, the last question for breast before we move on to urology. I'll give you maybe 50 seconds, it's quite a lot of text. Okay, so this one I just wanted to give you the tidbit that spironolactone does cause, that's supposed to be C is the answer, does cause gynecomastia, and if someone needs a potassium-sparing diuretic, you can switch them to a eplerenone, which is in the same class, but it doesn't have that side effect. Something to know, I'm not sure they'll quiz you on it, but it comes up at some point in the next 3 years, so bear that in mind. Okay, and gynecomastia is the enlargement of breast tissue, usually due to an imbalance between testosterone and estrogen. Can be normal in newborns or adolescents or older men. Does slightly increase the risk of breast cancer, and usually the cause is kind of, well, taking steroids is one of them, or kind of just changes in hormone balance for that reason. Yeah, can also be some drugs, steroids, other things. I don't think which one would be useful to learn. I think spironolactone is probably the most important one to know there. Otherwise, it's pretty like, doesn't come up that much. Okay, and then galactorrhea is the one that I get mixed up with gynecomastia because they both start with G. Just think lactose and then milk. So this is the one that's like milky discharge from the nipples. Can be due to a pituitary tumor that causes a raised prolactin. So think about that with a bitemporal hemianopia. If you're kind of compressing the optic chiasm, you'll get cutting of the visual field in that region. And then you can also get it with some drugs. So typically it's the first generation antipsychotics, which you don't need to know this year, just bear it in mind for next year. And then also hypothyroidism can cause it rarely. Okay, urology. Let's try and whiz through that. I'll give you 45 seconds-ish again. Okay. So your kind of clues on this one are burning pain on passing urine, slight temperature, and then it's tender and boggy when you're palpating the prostate. Um, the only thing here that's going to cause that is a kind of infection, STI picture. Usually in a UTI in a younger man, you're going to need to do an STI screen as well. If it's an older man, we don't tend to, but we do a kind of urine culture as well. So here you will do a urine sample to screen for STIs. PSA will go into, but it's not a helpful test for much. Biopsy of the prostate is way too invasive for a kind of next step investigation. And if you were thinking of a kind of prostate cancer, it's typically like craggy and large rather than boggy and tender. Doesn't tend to be tender. CT pelvis, again, is just a lot of radiation for not that much um, use. And then a blood test for HIV. We don't really have any risk factors here for him, so no need for that either. Okay, one of the helpful ways to classify lower urinary tract symptoms in men is storage and voiding. Storage typically, not always, but typically is a bladder problem or diabetes. I kind of think of diabetes as a microvascular slash neural problem, so that's going to affect kind of the innervation of the bladder. So these are some of the things that can cause storage symptoms, and then voiding symptoms is typically prostate related or something lower down that's blocking your ability to get fluid out of the bladder. How are you going to investigate? So you're usually going to do a urine dip, start with bedside tests. So urine dip, you can do bloods for renal function, you can do a DRE exam. You can helpfully get them to do a voiding diary, which will help with your history taking when you take an IPSS score. I don't think you'll need to do that in fourth year. It will come up in sixth year a bit more. But you're typically just asking, okay, how many times do you need to get up during the night to do a wee? What's your impact on your life with that? Are you finding that you have to strain? Are you finding that you have like a dribble at the end? Are you able to fully empty, or do you feel like you still have urine in your bladder afterwards? Those kinds of questions make up that score. And then you can literally calculate the number, and then there's like a flow chart for what you'll do with each number, which is helpful. You can do a urine flow study. That's quite extreme. Usually that's if someone's got like really severe chronic obstruction. And a CTKUB is helpful to rule out kind of sinister causes of an obstruction. Okay, so some prostate issues. The most common by far is BPH. It is just hyperplasia of the glands, so it's not cancerous, but it's just like enlargement of the glands. And most men get it, most over 40 will have some degree of hyperplasia. Typically just obstructs the urethra, so they just struggle to get pee out, and it leads to voiding symptoms. If it gets really bad, then they can get urinary retention, which can be chronic, which can need catheterization long term. Because you're not able to kind of constantly void, you have like stasis of urine, so that can lead to infection or stones. If either of those continue chronically, then you can get hydronephrosis or pyelonephritis, and then AKIs. Management. So medical management or surgical. Medically, you can use tamsulosin, which is an alpha blocker, so it relaxes the smooth muscle, or you can use finasteride, which prevents 5-DHT formation. I think it's in somewhere along the smooth muscle cyclic, like GMP cascade. Side effects, you do need to warn people that they can have erectile dysfunction, gynecomastia, or reduced libido with that. But I would just remember the names of these two. Typically, you start with tamsulosin because it's the kind of moderate, and then if things get worse or they're not responding, then you go to finasteride. Okay. Prostate cancer, typically it's an adenocarcinoma. On a DRE, it's a craggy mass, not typically painful, but will cause voiding symptoms. Um, Although less commonly than BPH, most of the time they just have enlargement of the prostate, and it's not cancerous. It can metastasize, which is where it starts causing problems, usually to bones, and it's sclerotic. So I think it's the one out of the ones that we learn, is the one that like builds bone rather than, I mean, breaks bone down rather than, no, sorry, builds bone rather than break it down like osteolytic. It's one of the commonest cancer diagnosed in men, more common in black men, and they do have a raised PSA on blood test, but it's not that helpful because exercising, ejaculating, or kind of having a DRE, anything that stimulates the prostate also raises the PSA, so it's not a very sensitive test. But there's some debate as to whether or not we should be offering it. If you need to diagnose it, you need tissue, so you're going to need to do a needle biopsy, which can be either transrectal, so through the bum, or transperineal, so through the tissue between the scrotum and the anus. And you grade it on a Gleason score out of 10. Okay, yeah, so this is just telling you that PSA is not that helpful. Lots of things can cause it to go up. A lot of people that have a raised PSA don't have cancer, and then 15 to 20% of people with prostate cancer have a normal PSA. So it's not a helpful rule in or rule out test. And it can cause unnecessary worry. So we don't typically offer it, but I think it will vary according to which doctor you talk to, because some like to and some don't. Management options, most of the time people just watch. It's not a particularly aggressive. Other things tend to get there first, in terms of mortality. But you can also do a radical prostatectomy. You can do radiotherapy if necessary, and you can also do androgen therapies, which is usually GnRH agonists, which has a kind of like it will increase your symptoms before decreasing them. I would be surprised if they ask about this in fourth year, but just to be aware of if they do. Okay, few questions. Okay. So a few things for this. Intermittent pain makes you think of colic, which is anything where a tube is squeezing intermittently down to push a fluid down. So you'll get it in your abdomen, and you'll also get it in your ureters when they're trying to squeeze urine down. If there is a stone, which is what a calculus is, then that's going to be an intermittent colicky pain. Another buzzword is kind of loin to groin, so it kind of moves in that direction because it's trying to push and it's pushing against a stone, which is really, really painful. And then they will pretty much always have some blood on a urine dip because you're squeezing around a stone. They helpfully put that he does a lot of heavy lifting, so just think of straining with that, and also has rarely has time for breaks at work. So you're thinking, is he drinking enough? Is he able to void frequently? If not, both of those things increase your risk of stones. And then just to let you know that calculus means stone. So renal stones. Usually it's pain is the most common presenting complaint. Loin to groin, colicky, really bad pain. People describe it as like the worst they've ever experienced ever. They typically have some form of blood somewhere. It might be microscopic, so you might not see it as frank hematuria, but it will be there on a dip. If we don't deal with it on time, you can get these two complications. So if you get an obstruction because of the stone, if it's big enough, then you'll get backlog and a hydronephrosis. And then if you're not constantly voiding, then you're increasing the risk of an infection, which can cause a pyelonephritis. Both of those can cause an acute kidney injury, which we don't want. So investigations, again, start with the bedside ones. So you'll do a urine dip and you'll do bloods. You're going to do renal function and calcium for those because high calcium. And some people have like a kind of familial hypercalcemia that just exists. And this is like the first sign of it is that they get frequent stones. And it can also be a sign of hypercalcemia in a patient that doesn't have any other symptoms. So do a calcium with the bloods. Look for infection, look for bloods in the urine dip, and then do a culture if necessary. Um, when you start thinking about what you're going to do for management, you can start looking at a CTKUB just to see where is the stone and what size is it. Um, and that will guide what you're going to do about it. And a flexible cystoscopy, it's possible. I wouldn't recommend it. It's a bit invasive for a stone, but can be done. Okay, so management, if it's less than 5 millimeters, it's likely to pass spontaneously. So you're going to go for a more conservative management. So that's just drink lots of water, encourage them to go to the toilet as frequently as possible, and then give them pain relief. So you need to remember that. So typically NSAIDs, IM or PR, diclofenac is the one that they go for, and then paracetamol IV if it's really, really bad. You can give tamsulosin here as well. So as well as helping with BPH, it can help with passing a stone. So that again just relaxes the smooth muscle and encourage it to pass. If it's small enough, If it's less than 2 centimeters, but more than 1 centimeter, we can do this kind of how do I describe it? It's like an outpatient procedure. So they come in, you kind of like an endoscopist kind of person will do it. You don't have to like come into a doctor's office and you can give them like shocks. Um, you need to warn them that they need to bring a change of clothing because it will get a bit damp because you need to put water on to help with the conduction and they might feel a bit sore and pass a bit of blood for a few days, but you can just kind of break up the stone into smaller fragments using the little shocks, and then that will help it to pass just by peeing. And then if it's really, really bad and they are like entering into AKI territory, then you're going to do your emergency management. So that's going to be an A to E approach. You might need to emergency decompress or insert a stent. And if they aren't voiding, you might need to put a catheter suprapubically as well. Okay, visible hematuria. Differentials to think about, pretty much everything, to be honest, but we do worry about visible hematuria, and especially if they're an older patient or if they have one of the exposures that we're going to talk about with their occupation, then we will consider a 2 week wait. So it's important to do a kind of thorough occupational history here. If they have any exposure to the kind of aromatic dyes or the aniline dyes that we talked about, then flag that as like a risk factor. If they've gone traveling somewhere and might have schistosomiasis, then that's another risk factor. Investigations, same as always. So start with the bedside ones first. You're going to do a urine dip, you're going to do a culture, you're going to do blood tests, look for infection markers, look for renal function, and then you're going to do 2 week wait if necessary, which is either going to be a flexible cystoscopy, which is like a camera through the urethra, or it's going to be a CT urogram with contrast. Typically, you do that if you think it's more of a bladder lesion because you can see if there's a leakage, you can spot it with the contrast. And if you think it's lower down than that, then you can do a cystoscopy. Okay, question. Okay, so with this one, this is just to highlight that the most common by far of bladder cancers is the transitional cell. Pretty much you're going to be thinking of transitional or squamous occasionally. Squamous, just think schistosomiasis. So you can either remember that because they're both S's, or you can think the reason it causes a squamous is because it's kind of chronic inflammatory, which is like if you're getting a callus on the skin, it's the same kind of idea. And that's also squamous cell, but just think SS. And then if it's not schistosomiasis, it's going to be a transitional cell for bladder cancer, typically. So yeah, more than 90% are transitional. Squamous is the next most common. So that's schistosomiasis. And then adenocarcinomas are just really rare. Um, it would be rude of them to bring this up, but yeah, some weird congenital defects do cause an adenocarcinoma, but most likely transitional for bladder cancer. Risk factors. So it is more common in elderly people and it's more common in men in a 3-to-1 ratio. Um, all of these carcinogens are risk factors. So smoking is for every cancer. Aromatic amines. So if they have an occupational history of any of these things, including the aromatic hydrocarbons, then be flagging it if they come in with frank hematuria. If they've had chemo and they used cyclophosphamide, it's very nephrotoxic, so be aware of that as well. And then kind of constant infection or inflammation, so constant stones or constant trauma or pelvic irradiation are the risk factors to be thinking about. Scrotal swellings, I think this is the last segment. Just an aside, if you're examining any lump, these are some helpful ways to remember how to do that. So you can do 4 S's and 2 T's. You're going to look at the site. You're going to report on how big it is. You're going to report on the shape and the borders. You're going to report on the skin, and then if it's tender and if it's warm. Otherwise, you can use the camphire mnemonic, which is what's the consistency? Is it fluctuant, hard, craggy, soft? Are there any attachments? Is it mobile or not? Does it pulse? Is it pulsatile? In which case you'd be thinking about an aneurysm of some sort. Is it fluctuant? Does it transilluminate? And is it reducible or compressible? That's more relevant for scrotal swellings because you can think about hernias there as well. Screenshot if you need to look at that in your own time. Okay, when you're palpating a scrotal mass, you can pretty much get the answer to what's going on just by palpating it. So can you get above it? If not, then it's probably an inguinal hernia because it's coming from the abdomen into the scrotum and you can't reach above it because it's like a direct pass through. Is it separate from the testis? If so, then think of the anatomy. It's more likely to be related to the epididymis. If it's kind of worm-like, then you're thinking of varicose veins. If it's tender and swollen and warm, then you're thinking of the kind of epididymoitis picture. Is it cystic or solid? So that's going to tell you if it's a cyst or not. And yeah, these are some kind of like explaining that a bit further. But that's just helpful to categorize what's going on with a scrotal mass. Important to think about testicular tumors. It's really common in young men in particular. So kind of like any other cancers, young men particularly, you need to think about this demographic with testicular tumors. It's associated with an undescended testes, so cryptorchidism. They might mention that in the stem. If so, then alarm bell should be ringing for a testicular tumor. Usually it's a germ cell tumor, but some, I think that should say, are seminomas. And you should also be looking for a kind of AFP or a beta HCG as your kind of tumor marker, which will help you decide whether or not, or which subcategory it's more likely to be. Other types of tumors are mentioned here, but they're just less common. And torsion is important to cover. This is a medical emergency, a surgical emergency, I should say. Usually it's a severe and sudden pain. It's unilateral, common in teenagers or young boys. Look for the cremasteric reflex. So that's which would be absent. So when you stroke the inner thigh, it should normally raise up. And if it doesn't, then you're starting to worry. And a definitive diagnosis can only be made intraoperatively, not by ultrasound. So usually it will say like, what's the next diagnostic treatment, and it will have ultrasound there, and it will just say go to theatre, and you should just go to theatre for this. And if you do need to go to theatre for a torted testicle, then you need to also fix the other side. That's another thing that they like to question you on. So typically there's like an increased risk if you've had it on one side of having it on the other. So anyone who's had any form of torsion will get both sides fixed at the same time. Okay. I'm going to give you 30 seconds for this one. Okay. So an ultrasound, basically we don't know what's going on. So we don't want to go straight to a biopsy or a CT pelvis because we don't want to cause him surgical harm or radiac harm. We don't think it's a prostate cancer that's metastatized, so a bone scan won't be helpful. Beta HCG, we don't know if it's going to be a germ cell tumor because we don't know if it's a tumor yet or not. So ultrasound is like nice and, the first line investigation to do to see what we're going to do later on. Okay, next question. I will give you 40 seconds for that. This one, think about the palpation of the scrotum. and what that can tell you. Okay, so basically the fact that you can't get above it when you're palpating tells you that it's an inguinal hernia, essentially. So yeah, doesn't transilluminate means it's not a hydrocele. Testicular cancer is typically like a mass separate to the testis, but we don't seem to have that here. Um, Again, not fluctuant, so not an epididymal cyst. He doesn't really have kind of infection signs, so it's not epididymolycitis either. Okay, that is all. Thank you for bearing with the timings of this one. If you guys can fill out the feedback form and put your emails down if you want to get the slides. Like I said, there's some slides that I didn't go through that you can look through in your own time if you found some of it difficult. Any questions, email me or ask now. I'll stick around for a bit. But otherwise, thank you. Thank you for listening.
Thank you.
No problem.